this is impact. So there are many, many interpretations of the word impact in the university, and as far as I know, there are at least 6 groups within the university who have impact in their name or in what they do. And so far as I know, they're all separate and none of us are connected to each other. But we were originated in what is now the Department of Public Health and Policy about 20 years ago. And in 2009, we got the first, again confusingly, Impact Award for knowledge exchange with policymakers in the real world for linking academic knowledge with policy making and policy implementation. So we do 3 things. We do the methodology, because our unit invented it. I do a very great deal of knowledge exchange and CPD. I have a background in education and teaching. So we have had delegates from over 40 countries come to Liverpool to learn how to do it. And we have gone to heaven knows how many other countries beside. And when I can do it online as well, there are a lot more countries who we will be doing it with. So I've been here 8 years, and I reckon that I've had face-to-face contact with probably getting on for 3,000 people in terms of knowledge exchange and CPD. So that's growing and telling people about methodology. But we also do consultancy. And we do consultancy in an open and transparent way. So all our HIA reports are published in the public domain. So good, bad or indifferent, we are there to be judged by our last piece of work. The vast majority of health impact assessments that are undertaken in the world are undertaken under commercial confidentiality and never ever published. And for colleagues from the sort of the environmental end of things, you will be used to that. It has always been the case in a health type background that openness and transparency were bywords. With the various political changes that have happened in the last year or two, that is no longer the case. So now, where people that we've known for 20 or 25 years would come and want a health impact assessment doing on a health-related subject that would of course be published in the public domain, they are now being done under commercial confidentiality. Okay? Because there's always a political with a small p, a political sensitivity in doing a health impact assessment. But we've done a lot of them. I've done about 20 standalone independent consultancy HIAs, and every single one is different. There are similarities, but they are all different. So why do it? Okay. This is our definition that was adopted by the World Health Organization. We do it to inform and influence decision making. So the emphasis really should be on influence, with a small p for political, because we are there to influence decision making and decision makers. There is evidence that going through an HIA experience, an HIA process, changes the way people think and act. And there's something called Health in All Policies, which is a global UN drive. So whether you are thinking about a building policy, a planning policy, a health policy, crime, education, whatever, engineering policies, they should have health in absolutely all of them. Because it is about enhancing the positives as well as mitigating the negatives. And I pause there because almost all the other types of impact assessments, and there's about a dozen that we commonly talk about, but there's more than that. So almost all the other forms of impact assessment only focus on mitigating negatives. So they take a risk reduction, technocratic approach to mitigating negatives, usually within a legal context and a regulatory framework. Health impact assessment doesn't do that. We have no boundaries, and we are about accentuating the positives, and we are about influencing policy and policymakers. Okay. So that's the added value of HIA. Any other impact assessments that you know about, when everybody goes, another methodology, something extra to do, it's not. It's just when you add on that population health angle through health impact assessment approaches, you are looking to accentuate the positives. And that can be short, medium and long term. So that can be definite, probable, possible, speculative. We are allowed to horizon scan because there is no regulatory boundary on HIA. So we can speculate on what the impact of a decision or a piece of legislation might be on children that aren't yet born in 30 or 40 years' time. And it's hard to find pictures of health impact assessment and the benefits. So this is just one way I try and explain it. So any of the age groups that you can see in any of these slides are all the sorts of population groups that can be included and impacted upon by decisions made to do with policies, programs, projects or plans. And you can do HIAs on all of those different things to affect all these different target groups. And I've tried to capture some different subjects here as well. So the first thing you talk about when you talk to anybody about health is, what do you mean by health? Because people who are used to thinking about quantitative measures and about risk reduction approaches and about health service approaches and the commercial risk, the costs of commercial risk in industry and things like that, they are very much about counting what happens. They are very much about thinking the cost of something going wrong. And health impact assessment is about saying, but if you improve things and events don't happen, you can't count them if they haven't happened. So you are into measures of well-being and looking for outcome measures that indicate how policies, plans, projects, and 4 Ps anyway, as how they accentuate the positive. Because in this country, our elected members do have a responsibility, like there is a financial accountable officer, there is an accountable officer for the health and well-being of local populations in this country. So somebody is responsible. So certainly in this country, they shouldn't be making policy, plan, project decisions that might have any detrimental impacts on health and well-being, mental and physical, of the population, either now or into the future. And I'll guarantee that that doesn't happen in real life. Okay. But that's what HIA is about. It's about, and it includes the information that they don't want to know about, because it includes the views and the voice of the public. So if I did a housing one in Manchester a few years ago, and the Housing Association said, we don't want to know about stray dogs and what they leave behind, and we don't want to know about garden fences, because it was all open plan housing on the estate. And you have to be very clear at the beginning and say, if your community want to talk about dogs and fences, you will be talking about dogs and fences. Because health impact assessment brings a reciprocal responsibility between the people who make the policies and the decisions and the stakeholders, the community, because the community give their voice and their evidence to inform the policymakers and the decisions. So if the decision makers decide not to do something because it costs too much money, or they don't have to within a regulatory framework, they've then got to be prepared to explain to their stakeholders why they didn't do it. And in 10 years' time and 20 years' time, why things are going pear-shaped. Okay. So these are the reasons why. I've got some environmental ones in there. I haven't got a pointer, but never mind. The one above the cyclists is the well-known tourist island near France that I was just mentioning before, where they were building the waste incinerator and the chimney on the coast. And this is the computer-generated picture of it by the Y in your policy. And they thought they'd told the public that it was going to happen because they put a story in the local newspaper in English, and nobody wrote any letters of complaint. And the facility is 30 metres high. And 2 years later, I looked online and all hell had broken loose, because once it got to about 15 metres high, the public started to see it and said, nobody told us anything about this. And that's because their engagement process wasn't participative. They didn't engage with the population, they didn't take any account, and the whole thing just went pear-shaped. It's still being built, of course, because the planning decisions were made, but it's all about power and control, politics with a small p, and how that brings that reciprocal responsibility. But it is about accentuating positives. So you can sell it to developers, you can sell it to elected members, municipal representatives, because if they think in a health impact assessment way, they should be able to make good, better, healthier decisions on behalf of the populations. So they should see an advantage in wanting to accentuate the positive rather than just only mitigate negatives all the time. And certainly when it comes to using climate change, and I know Michael Beer in the Risk Institute has wonderful pictures of smashed up tankers and bridges that have fallen down all around the world. Well, you guys know the evidence. Why aren't the decision makers making the decisions in light of that evidence? And health impact assessment would give them a way of doing that. And then they can be held accountable. Why didn't you build bridges that wouldn't blow down? Why didn't you build ships that wouldn't, collapse and all the rest of it, leak when they sink at sea? All those sorts of questions. Housing, planning, education, disability, transport, children, you name it, it's there. This is the model of health that was originated by Professor Margaret Whitehead in our Department of Public Health and Policy in 1991 with a guy called Göran Dahlgren from Sweden. Okay? And this is the qualitative end of health. So you have disease reduction, prevalence, incidence, all quantitative numbers in a disease-driven paradigm at one end, and you can do health impact assessments at that end of the spectrum. But there is a spectrum, and this model of health is at the other end, okay? So this is a wide, socially driven, qualitative driven model of health. This is because the determinants of health lie outside health services. So in the middle, you can't do anything about your age and sex. So they're the biological, hereditary type factors that you can't really change. I am in a vulnerable population group because I am ancient, and I can't do anything about that. Okay? So that's me in the centre. The red layer is about sex and drugs and rock and roll, smoking and drinking and physical activity, and the way we decide to live our lives, and the decisions that you make about the way you live your lives with your family. And if I may digress for a moment, if any of you ever saw the television programme called Shameless on Channel 4 with a character called Frank Gallagher, that is real life. When you are talking about health inequalities, that is real life. So I don't have a television, so I can't see Benefit Street, but I guess Benefit Street is the same thing. Okay? Real life is not the way we live it in our nice middle-class professional, academic lifestyle world. So when we're talking about the determinants of health and closing the gap in health inequalities, this is what counts. The amber layer is how our families and our communities relate to each other in neighbourhoods. So our colleagues in architecture and place and geography, I do a lot of work getting closer and closer all the time with Thomas Fisher and Sue Kidd and the people in civic design. This is about how you plan places and spaces for people to live their lives and how those communities interact. And I do that because that's about people living their lives on the ground. But there's also what I call a vertical element, because we all make choices about how we engage with the authorities. Okay? And for example, single parent families, young mothers with children who are on low incomes and living on benefits, there is a whole social sciences literature in fairness and social justice that will show things like young single mothers completely withdrawing from any contact with the authorities because they are just too frightened of losing their children. So there's some complex psychologies going on, and I don't have a pure social science background either, but it's the people end. It's why people do things from a pharmacological point of view, why people choose or don't choose to engage with primary care services, because they either do or they don't want to get on a primary care disease register. Take me and my family. My husband takes 5 tablets every morning and an inhaler, and then a steroid and an inhaler at night, because he's been caught in the system, and his doctor is getting paid £7 every single year for a review in primary care because he's on a disease register. He's probably healthier than I am, even though he takes all these tablets and medicines, but he only gets the prescriptions because he keeps on turning up and he's in the system. I won't go anywhere near the doctors. When I fall over, I will go near a doctor because I've got no intention of putting myself into a position where I will get those indirect impacts of the sick role and the stigma that goes with being sick and all those social science things that go with it. You know exactly where I'm coming from.
Yeah, being at risk is something that is quite prevalent in the society today. There are a lot of people at risk for something.
And the doctors will love it to death. The more people they can get on a diabetes register or a respiratory disease register or anything else like that, it's all income for them. Okay? And then, of course, you have the pressures of the big economic pressures of pharma as well. And you know an awful lot about that. Okay. So there's this vertical element of engagement in social and community networks. Then there's a whole layer about living and working conditions. There are whole literatures and whole careers built on each one of these and more. So you have agriculture and food production, GM foods, food safety, food mountains. CJD comes into all those sorts of things as well. Okay, horse meat in food, antibiotics in chicken, salmonella, you name it, it's in there. Health protection comes in there in a big way. The the life achievements of children are directly dependent on the educational achievements of the mother, and the greatest effect is on children before they reach the age of 11. So if you know any mother who still has any influence on what her children are doing after the age of about 8, 9, 10, 11, you are not in the majority of the population, basically. And higher the educational achievement, the sort of higher up the pyramid, you are getting to the smaller numbers at the top. Housing is absolutely crucial. What sort of housing, what sort of shelter, where do you put it, what sort of facilities does it have? Massive influence on individual and population health. Water and sanitation, even in the developed countries, even in Australia, because of flooding and climate change, whether you believe in it or not, they are having difficulty providing water for their populations now, even in developed countries, never mind undeveloped countries. Same for sanitation. And underlying all these things are the mental health issues, the psychological well-being issues. Being in work and being out of work, it can actually be more detrimental to your mental health and well-being to be in a precarious, low-paid, unsafe job than it is to be in decent employment or totally unemployed. You know, even within the higher education sector, that is true, just at a different level. Okay. And then right on the outside, you have the big issues of the socio-economic determinants of health, cultural determinants of health, and environmental conditions. You know that there's lots of talk about green space and providing spaces for people to exercise and, you know, cycle and all the rest of it. But culturally, there are many of the minority ethnic groups who will not go anywhere near a green or open space because if there are, take a city like Liverpool, if there are flats developed with big windows that overlook the parks, the minority ethnic groups will not use those parks, the women will not use those parks to take their children for exercise because culturally they are not allowed to be out there where the windows can see them in public. In my health promotion days, some ethnic groups, you can't talk about breastfeeding. You can't talk directly to the women. Sometimes you have to talk to the men and the brothers and the fathers. Okay? So there are huge cultural issues in that. And the point about the determinants of health is that these are the things that can be changed en route to diseases. So the simple example is, if lung cancer is a health outcome, what's the health determinant? Smoking. Okay? Really simple example. So these are determinants, things that can be changed, can be considered en route to a health outcome. So it's influencing and changing the determinants of health because these come before the outcomes. Okay? And it works outwards and it works inwards. For the planners amongst you, you may be more familiar with seeing that model. You can see where this has come from. This is by Barton and Grant. I put it in case there were any planners turning up this afternoon. So Barton and Grant got into trouble because they didn't acknowledge Dahlgren and Whitehead at the beginning. But this is fairly ubiquitous in planning circles now. Uses a little bit more of the planning language, but you can see where it's derived from. There is another version now as well, which completes the circle, and that is about mental health. And we were involved in doing that one. So it talks about resilience and social cohesion and inclusion and exclusion when the version is expanded into a mental health sphere. So what is it? As Alex Scott Samuel and colleagues invented it in 1998, it is a combination of procedures, methods and tools by which a policy, programme or project may be judged as to its potential effects on the health of a population, not individuals, a population, and the distribution of those effects within the population. So, what does the combination of procedures, methods and tools mean? That means using a balance of qualitative and quantitative research methods. Not one or the other. Numbers do not outweigh or have greater value than words. Computer spreadsheets count every bit as much as what the lady down the road stands up and says. Okay? They have equal weighting in health impact assessment. And you use robust methods and tools from qualitative and quantitative, but in a timely, applied fashion. So you don't think of an intervention that you might like to have a go at testing, do a baseline, do an intervention, and then evaluate it. You do health impact assessments upstream. So before you even think of an intervention, before you even sign off a policy or a programme or a plan or a project, you do the HIA before that, upstream, to inform it so that it can be the best it possibly can be. Talked to a group of students from the tropical school from Sudan, and they'd had a war in Sudan, and the new president had been elected to get rid of all the dreadful effects of war. Okay? And so these guys had come over to learn methodology, and they knew about pilot studies to improve the intervention that they would then evaluate. And I said, well, if you do the health impact assessment first, you will have a better pilot study to test. And if you have a better pilot study to test, when you do the intervention, hopefully you will get a better evaluation out at the end. So when we build health impact assessment into research bids, if it's a 20-year RCT, it's not likely to have HIA in it. But if it's something like a 4 or 5 year study, and commissioners of research want to know what's going on along the way, we build in HIA at 2 or 3 points in a 4 or 5 year study to inform them. It's a judgment. You gather the evidence, the assessors see what's going on in that window of time, and they're looking at the effects on a population. Now, whether that's a geographical population, whether that's a population of people with certain attributes, it doesn't matter. It's a defined population, and it certainly isn't always geographic at all. So you define your population. And then the quantitative stuff really comes in with things like demographic profiling, the baseline, if you like, about the health and well-being status of the population you're talking about, so that you can then see and project and estimate what the likely impacts might be of that policy, plan or programme, and then you can accentuate the positives and mitigate the negatives based on those projections and estimations. And this definition from our department was adopted by the World Health Organization. And the core values, democracy. So this is about participation. If you haven't got community participation, it isn't really an HIA. You can do desktop exercises where you just sit and have a look at what you can find out there in the ether. But technically speaking, because this is about influencing people and listening to the community voice and balancing quantitative with qualitative, if you are doing an HIA, if we're quality assuring or appraising or giving expert opinion and advice when we look at other HIAs or peer reviewing HIAs, if it doesn't have decent community participation, it isn't an HIA. Okay. So it's democracy. Ethical use of evidence. If there's gaps in the evidence, we say so. If it's good evidence, we critically appraise and we make a judgment using critical appraisal tools. We don't exclude evidence just because it comes from a political lobbying group. There are many sides to arguments. We include them all in. We include the nutter from the British National Party who's making political extreme statements. We include the people who would be on a professional disciplinary if they made those, anything with an ist on the end, racist, whatever.
Even feminists. Wow.
Pardon?
Even feminists.
Absolutely.
That's radical.
Okay. There are all the lobbying groups in the environmental world and all that sort of stuff. You mentioned one when we were chatting before. They're all in, and you acknowledge their standpoint. We usually edit out the swear words, but we leave the rest in. And you try and balance it. You present the evidence to the decision makers. They make the decision, which is why it's about equity. And equity is doing whatever you've got to do in terms of fairness and social justice to provide and enable the people and the populations and the groups who are least able to participate and express their voice to join in society one way or another. So when the economy is now recovering in the UK, but that's only because the data is as it is, okay? The rich will carry on getting richer, but this is about doing something to improve equity for the other members of society so that the gap doesn't go on getting wider and wider. And it's always been about sustainable development, not just cutting down trees and things like that. This is about the sustainability of the recommendations in an HIA. This is why I was talking about that reciprocal responsibility between the decision makers and the population. And we add openness and transparency. Have the press in. It's a nightmare, but it's much better to have them in and seeing what's going on than to exclude them. Have the developer in. Have the proposer, the policy proponent, in. They don't have to have voting rights in the decision-making process of the steering group, but have them in. Be open and honest about who's paying. Warts and all, limitations and constraints, gaps are all included in HIA to be open and transparent, because then people can see, and they're not daft, they can make a judgment for themselves. And then you express all a bit about vested interests and potential sources of bias and all that sort of stuff. And it's all about addressing health inequalities. Our colleagues in Australia, and wherever you go in the world, wherever there is a centre of excellence in health impact assessments, Ireland, Scotland, Australia, New Zealand, Sweden, Denmark, wherever it is in the world, they all came to Liverpool to learn how to do it here. Okay? So our good colleagues in Australia have come up with a typology for HIAs. The ones that are mandated, either statutory or mandatory, and some countries do make it a legal requirement, they tend to be this sort of HIA. So they meet regulatory or statutory requirements, and they're basically about mitigating negatives. And the role and values, the qualitative aspects, don't see the light of day. These are the tick box exercises. I've sat in a local authority and watched planning decisions for the next 30 years be made, and they wouldn't even let us sit in the meeting. Never mind say anything, or say, what about health impact assessments? Okay, no chance, don't come to the meeting, not allowed near the meeting. These are tick box. These are the ones that are done sometimes like environmental impact assessments, equality impact assessments. After the decision has been made, it's a box that they've got to tick to say that it's been done. Sometimes they may be done voluntarily by organisations who are putting up the proposals, and they are prepared to look at maximising positives. Corporate social responsibility, okay? Buffing up the image of the commissioner, pharma, health service providers nowadays, they want to buff up their corporate social responsibility. All the supermarkets, all the food people. So they will have a bit about accentuating positives in, okay? But still, those qualitative philosophical values are still only implied. And if we make a qualitative judgment, this is sort of moving towards the better end of quality HIA that is down this Dahlgren and Whitehead model end of HIA. So these are the ones that are done by people like voluntary groups, what used to be local authorities with a certain degree of independence, or a primary care trust, a health organisation that had some independence. So they had a more advocate type role on behalf of a population of interest. So this is where the real values of HIA were starting to be more explicit in these sorts of HIAs. And the real good ones are the community-led. Okay. Some of the best HIAs are done by community people, in the community, for the community, by the community, and there is never even a formally written up report. This is not about academic impact and ref. This is about impact in a population, what works out there on the ground in real life. And these have the community values and judgments absolutely central to what they do. So we do a great deal of work with the voluntary sector, with community groups, with the third sector. If they're not right in the thick of it, it's not a good HIA based on that Dahlgren and Whitehead model. If you want to be technocratic about it, this is the methodology that we use. My colleague Alex Scott Samuel hates putting things in boxes because he thinks it makes everything linear and finite, and he certainly has a point in that respect. So you'll see the same thing in our original methodological guide, just as a list of bullet points. It's exactly the same. This side are the procedural aspects. These are the things that you do before and after a health impact assessment is done, in inverted commas. These are the things that bring the influence and the impact of doing HIA. And if you don't get it right before you do an HIA, that will massively affect the likelihood of implementation of recommendations. The procedural things and getting it right before you start are the things that will tell you whether or not your HIA is going to be successful, whatever that means. Okay? Same thing with the research bid. If you get it right before you put the bid in and you do the work upstream and you think about what the outcomes are going to be at the end and the IP, exactly the same principles. Okay. So you screen and scope. You have a look at what the problem is, what the issue is, what the topic is. And you do a bit of fishing around the literature and community people, and you get a feel for how many determinants of health you're going to have to look at, what sort of resource is going to be necessary, what the time scale is, what the resource is, etc., etc., etc. You do some demographic profiling, you get an idea for the size and shape of the work. And then you make a decision, or somebody makes a decision. Do we need to have an HIA done or not? We advocate, because of health in all policies, we advocate that everybody everywhere does that screening and scoping level of HIA, whether or not there is ever going to be a more detailed HIA done. Because it's the thinking about it at that level that spots the gaps and gives you a heads up and begins to make people talk to each other and think more widely outside the box. But if you do make a decision to do an HIA, do you commission it externally, or have you got the resources within your partnership across organisations to do it? So you need to look at the team that you have available and the skill mix, and where's the expertise. So that's where I say bring in the academic evidence, whatever the mathematical modelling is, wherever the academic expertise is. This is why I'm in the Risk Institute. I'm talking to all our engineering and so on colleagues and the climate change people and all that sort of stuff. Because the more expertise you can bring in, that's where you're looking for your evidence in HIA. You don't invent any new stuff, you just bring together the expertise. So this gives researchers an in to working with the policymakers. And when you actually do an HIA, all these methodological steps, you use that evidence and that data. You use those expert key informant views. You talk to the people in academia or wherever, the industrial experts, we've mentioned the nuclear people and all that sort of stuff. And you bring them in and you use their evidence. So you do a political policy analysis of what, local authorities don't agree with, regional authorities don't agree with the government. We heard before when I mentioned the public health responsibility, it's different in different parts of the country. So you have to put it in a political context. You do your demographic profiling, as I've mentioned. There is a huge risk at the moment around data sharing that affects absolutely everybody in this country who is registered with a doctor, and about how your data will be shared in the future. And if it goes through, every single one of us, whether we like it or not, unless we opt out, our personal medical records will be amalgamated, allegedly anonymously, for research purposes and other purposes, but also including for the commercial companies who are providing health services as well. And the big worry is, of course, if you opt out of that, will the hospital still be able to talk to your local physician? And that's what everybody's worried about at the moment. But it's huge, because there might not be any health data in the future at all for anybody to do any research on, or plan any health services on, or commission any health services, unless they're in a position to buy the data. Qualitative and quantitative data collection, that's everything that you know and love about the qualitative research methods like focus groups and semi-structured interviews and Delphi techniques, and all the qualitative research methods. And the quantitative stuff, if you can get in and resource the people who can do the fancy modelling and the estimations and the multiple choice decision analysis and all the other fancy things, if you can get that in, if it exists in the public domain, you drag it into your HIA. But very, very, very rarely is it resourced and paid for from scratch in an HIA. It's just too expensive. And it's not timely with respect. Taking a couple of years to come up with a new mathematical model is not timely enough for decision makers. So you get what is out there from all these different sources and you bring it together. And so the assessor or the assessment team make a judgment in impact analysis. And they consider all the evidence and they make their best judgment. And just like environmental impact assessment, it is a judgment. Okay? It's not quantified, it's a judgment. How strong is the evidence? Where did it come from? What balance can we put on it? Which subject has the highest priority for the population, for the community? And from that, you will get a whole list of impacts that you have to establish priority in. And again, you use Delphi techniques and the proper methods for consensus building. And you develop some recommendations. And you write your recommendations in language that will grab the policy and decision makers. You don't write it in scientific language that you understand, because then it's not going to be picked up and used. You write it in their language. However simplistic, however lay that is, you write it in the decision maker's language. You have one big technical scientific report lodged somewhere, and then you work with an executive summary that's written in the language of the people who are going to be implementing it. Because when you're talking about communication and understanding of risk and all that sort of stuff, if you're not using the right language, you might as well not bother. Okay. So you write the recommendations to suit the audience, and you undertake a process evaluation at the end so that you can learn how to do it better next time. Then the steering group picks it up, presents the recommendations to the decision makers, and you should always think about the monitoring, impact and outcome evaluation, and you need to resource this right up at the beginning, because if you don't build it in at the beginning, it won't be paid for at the end. And that's the same with research as well, I think. You know, if you don't, it's no good getting €1 million to do a research study and then realising you missed something terribly important out. And by the way, we'd like to do these extra 35 telephone surveys that cost £20,000 each. It's going to make a hole in your budget. So when you're doing health impact assessment, you have to cost it in at the beginning. So technically speaking, that's how you do health impact assessment. Your recommendations should be smart, as specific as possible, as measurable as possible, maybe, well, they should be achievable and realistic, but certainly time-bound. So it's not about motherhood and apple pie in 30 years' time. It's about, we would like 6 jobs for males and females aged 18 to 25 on our building site, and these jobs must be in place, and training and support and induction must be made for these young people, and we would like 3 jobs per 1,000 of the population in the age group 8 to 24 years. We would like those jobs to be in place within 3 months of the construction phase starting. Really specific, because then the decision makers really know what it is you're recommending. Okay? Short, medium or long term. So if I haven't already emphasised it enough, the key output is the set of evidence-based recommendations designed to influence the decision makers. So research comes up with evidence-based recommendations, but not necessarily specifically designed to influence decision makers. And these are just some more pictures of things that you can do HIA on. All the people with the buckets on their heads, that's a veterinary project. So I love talking to, who is it that does, is it Global Health? And in the tropical school. This was a veterinary project, and they built the mound at the back to trap the water for irrigation for cows. Wonderful, healthy cows drinking water, lovely. But the water didn't flow very well. And the people who lived there had these sorts of difficulties about getting drinking water. Okay? not easy to get drinking water. So the veterinary project made lots of water easily accessible for the population. So the population go and get the water that the cows are in. So you've got infection and heaven knows what else from the cows trotting about in the same water that the people are now taking. But you've also got a wonderful little worm that lives in the water, and it causes a disease called schistosomiasis. And schistosomiasis is wonderful because when you go paddling, I'm a bit eccentric, so when I use wonderful, pinch of salt. When people go paddling through the water, the little worm burrows through the skin and gives them schistosomiasis. So the veterinary project improved life for the cows, but the unanticipated impact was that the people would go and get the water, and therefore the schistosomiasis rockets. So health impact assessment screening of a veterinary project might have realised that, and they could have made recommendations to mitigate. They could have said, you need to provide some water pumps for the population because otherwise they will all go in the water and get schistosomiasis. Okay. Lots on road traffic and gender issues. When you build a road into a big extractive industries development, no pavements, so this lady with the wood on her back is walking along the apron of the road. Huge traffic industry issues, and they would probably have been subsistence farmers. So the men are probably now driving along the road to the nearest encampment and town to get cash for crops that they're now growing. And the men tend to stay in town and pay for sex and drugs and rock and roll, and the women don't get the money, whereas the women used to be the subsistent farmers back in the village. So huge gender issues as well. All of these types of things you can do health impact assessments on. There's our cyclists, population density, emissions, air pollution, environmental pollution, you name it, health and safety issues on the beach. You've only got to walk down the beaches and the needles and the glass and all the rest of it for the issues there. Population itself could have health impact assessment done on it. Housing, ageism, unemployment. Our second methodological guide, this one, was done on in 6 countries on the employment strategies of 6 countries. And of course, nowadays, in this country, with the changes in pensionable age and so on and so forth, what are the mental health implications of having to carry on working when a state pension is going to be further away? And when you start talking about finances, people don't go bankrupt anymore in this country, and they changed that centrally. They changed the government way of working, the policy, so that people don't go bankrupt, because they knew there was so much debt happening out there that the stigma and mental health impacts were going to be so great, and the suicide rates are rocketing anyway because of the austerity cuts and the global financial crisis. Huge, 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 huge issue. Did an HIA about debt advice. Most of the debt advice in this country is given by voluntary sector organisations, and the voluntary sector organisations had their grants cut by 50% overnight when the coalition government came in. Huge, huge issues of finance and debt when generations of people have been encouraged to live on credit. Housing, planning, sanitation, transport, you name it. Upstream health impact assessment, please, at the screening level. Oops, wrong way. Houses of multiple occupation, gentrification itself. Where do the drug users and the homeless people go if you gentrify the housing? if you push up the housing prices artificially, they're going to go somewhere. So you're only moving the problem from one jurisdiction to another. Transport, trams, the green environment, all these things have health impacts. Electric batteries in cars, you know better than I do, the actual impacts of generating the electricity. Biomass, everybody's going for biomass burners because it's green, and that's the green policy. Okay, huge implications, air pollution, biomass. Women and children are much more affected by the smaller particulate matter than men. But you know, hey, biomass is green, the government are paying you to do it. You know, build a biomass plant next to a primary school. Does absolutely nothing for health inequalities. And that's about it, really. So, something to think about.